Hello, it's Dmitry again. Today we'll be covering the last two sections of the microbiology chapter from the First Aid for the USMLE Step 1 textbook, the 2025 edition. Again, I'm reading from the 2025 edition. The book that you see behind me on the screen is the 2017 edition, which is largely the same content, but there will be some variations. Now, this is going to be covering the systems section of the microbiology chapter, as well as, I believe, if I can find the page, I like to say it's the pharmacology section, if I'm not mistaken. If memory serves correct, which I think it probably will, we would also be covering the antimicrobials pharmacology. So they say, oh, it's the antimicrobials. It's the pharmacology for microbiology. Now, so we'll be covering those two sections today. So that'd be section 6 and section 7. Haha, so funny. From the microbiology chapter today. That should take about 2-ish hours, perhaps. We're starting on page 174. We'll be wrapping up on page 199 for reference. So let's get into it. Microbiology systems. Normal microbiota dominant. Neonates delivered by C-section have microbiota enriched in skin commensals. So this is location versus microorganism. Skin, Staph epidermidis. Nose, Staph epidermidis colonized by Staph aureus. Oropharynx, Viridans group Streptococci. Strep viridans. So remember, Strep viridans is involved in dental caries and stuff like that. So bear that in mind. When you think about, where's it normally located? It's located in the oropharynx. Dental plaque, Strep mutans. Now, Strep mutans, I believe, is a subgroup of viridans. Am I confusing that with something else? Let me just maybe confirm. Strep. Yes. Okay. I'm correct. Yes. Streptococcus mutans is a member of the viridans group of Streptococci. So bear that in mind. Dental plaque, specifically Strep mutans. The colon, B. fragilis, more so than E. coli. And I want to make sure I'm not saying anything incorrectly here. I want to confirm B. fragilis is specifically referring to Bacteroides fragilis. Okay, I was not sure. I was not confident in an answer. Bacteroides fragilis, more so than E. coli. The vagina, you're going to have lactobacillus colonized by E. coli and group B strep. So, okay, lactobacillus. But you can have colonization between E. coli and group B strep. So group B, by the way, is strep agalactiae. And agalactiae can cause a problem for the woman who's giving birth, because when she's giving birth, it can cause the agalactiae can actually infect the neonate. So just be aware of that as well. As we have to give the patient penicillin, I believe, before, I think at 35 weeks of pregnancy, so that when she actually delivers a child, there won't be an infection of the neonate by group B strep agalactiae. What about bugs causing foodborne illness? What about that? Staph aureus and Bacillus cereus food poisoning starts quickly and ends quickly, exotoxin mediated. Microorganism and the source of the infection. So Bacillus cereus is caused by reheated rice, food poisoning from reheated rice, B. cereus. Sure. I just remember that the consonants, or I guess it would be like a liquid consonant a little bit. This for cereus is rice and cereus have the same consonants. So both have an R in them. So that's how I remember it, even if the vowels are different technically. So rice, cereus. C. botulinum. Clostridium botulinum. Improperly canned foods, toxins, or raw honey, spores. Bear in mind, the canning of foods for botulinum is associated with the adult infections, while the raw honey spores are associated with infant infections. Clostridium perfringens, caused by reheated meat. E. coli, O157H7, undercooked meat. Listeria monocytogenes, caused by deli meats and soft cheeses. Salmonella, caused by poultry, meat, and eggs. Staph aureus, caused by meats, mayonnaise, custard, and with a preformed toxin. For V, parahemolyticus, and this is Vibrio parahemolyticus and Vibrio vulnificus, is the source would be raw, undercooked seafood. Raw or undercooked seafood. And there's a little note right there that says, Vibrio vulnificus predominantly causes wound infection from contact with contaminated water or shellfish. So vulnificus can be spread, through food, but it's more likely to be caused by, like a wound touching contaminated water or shellfish. Bugs causing diarrhea, bloody diarrhea, Campylobacter, comma or S-shaped organisms, growth at 42 degrees Celsius, Entamoeba histolytica, protozoan amoebic dysentery, liver abscess. E. coli, enterohemorrhagic E. coli, I should say, O157H7 can cause HUS, hemolytic uremic syndrome, makes the Shiga toxin. Enteroinvasive E. coli. And I want to make sure I'm saying this. When you say enterohemorrhagic E. coli, we mean EHEC E. coli, EHEC, EHEC E. coli. Enterohemorrhagic E. coli, that's O157H7, that can cause HUS and makes Shiga toxin. What about EIEC E. coli, EEC E. coli? That's enteroinvasive E. coli. Invades the colonic mucosa. Okay. Salmonella, non-typhoid type. Lactose negative, flagellar motility, has animal reservoir, especially poultry and eggs. What about Shigella? Shigella, it's lactose negative, very low ID50, so it's a very low infectious dose. Because it very low for that. Okay, produces Shiga toxin. Human reservoir only. Bacillary dysentery. Okay. What about Yersinia enterocolytica? Well, you have daycare outbreaks, and pseudoappendicitis for enterocolytica. What about watery diarrhea? So those are the bloody diarrhea ones. There's a lot of things that have cause diarrhea. So just be aware which ones cause bloody diarrhea, which ones cause a watery diarrhea. Bloody diarrhea, think about Campylobacter, E. histolyticum, EHEC E. coli, EEC E. coli, Salmonella, Shigella, Yersinia enterocolytica. Think about those, okay? Histolytica, enterocolytica, a lot of E. coli types, EEC and EHEC, and Shigella, and Campylobacter. Okay. What about the watery diarrhea types? Clostridium difficile, pseudomembranous colitis, associated with the antibiotics and proton pump inhibitors, occasionally bloody diarrhea. So occasionally bloody diarrhea, in the case of C. difficile. Clostridium perfringens also causes gas gangrene. Enterotoxigenic E. coli, this is ETEC E. coli, ETEC. Traveler's diarrhea produces the heat labile toxin, ALT, and the heat stable toxin, ST. So keep that in mind as well. And those are a watery diarrhea, fundamentally, the ETEC toxins, heat stable, and the heat labile. What about protozoa? Giardia can cause a watery diarrhea. It causes one that's very foul smelling. And Cryptosporidium causes a watery diarrhea. What about Vibrio cholera? Vibrio cholera is a comma-shaped organism, rice water diarrhea, often from infected seafood. And in viruses, this is a list of stuff. Okay, norovirus, which is also called Norwalk virus, which is a calicivirus, most common cause in developed countries. In developed countries, most common. When I mean developed country, I mean like a Western country typically, or maybe like Japan or Korea or South Korea. Rotavirus is another category. Decreased incidence in developed countries due to vaccination for rotavirus. And then you also have enteric adenovirus as well. What about, let's go down a little bit, common causes of pneumonia. This is a list right here you should be aware of. So common causes of pneumonia. You have neonates. Oh, this is like a different kind of period of time. So you have neonates, et cetera, et cetera. Okay, so what about neonates? People who are less than 4 weeks of age. Most likely causes pneumonia, group B streptococcus, that's Strep agalectiae again, and E. coli. What about children between the ages of 4 weeks to 18 years? That's a pretty broad category, by the way. Oh, they're children, and it's like a guy who's 17 years old and a child that's 17 years old. Sorry, okay. And someone who's 4 weeks old. It's a little bit different of a category, I would say. But whatever. They said, what are the biggest things you would see here? Viruses like respiratory syncytial virus, RSV, Mycoplasma species, Chlamydia trachomatis, which is between infants and 3 years of age, Clostridium, pneumonia. Okay, pneumonia, school-age children, see pneumonia, but what do we mean by here? Again, I'm probably dropping the ball a little bit on this one because I should know what the name is off the top of my head, but I don't, and I'll probably know when I actually hear it again. Okay, so it's chlamydia pneumonia. Okay. Let's go back to it. So viruses, RSV, mycoplasma, chlamydia trachomatis, chlamydia pneumonia in school-age children, strep pneumonia, and it says here runs, may, cough, chunky sputum. It's kind of gross, but basically for pneumonia in kids, you might have RSV, mycoplasma, chlamydia trachomatis, or chlamydia pneumonia, strep pneumonia, those categories. Okay, what about adults? Mycoplasma pneumonia, which again, mycoplasma pneumonia gives you an atypical kind of pneumonia. Chlamydia pneumonia, strep pneumonia. Strep pneumonia gives you a classic normal, I wouldn't say normal, but like almost like a low bar type of pneumonia. Viruses like influenza. So those things can cause it in adults. What about people who are adults 40 to 65 years of age? So that's 18 to 14. Mycoplasma, chlamydia pneumonia, strep pneumonia, and viruses like influenza. Adults 40 to 65 years of age would be strep pneumonia, Haemophilus influenza, anaerobes, viruses, mycoplasma pneumonia. What about adults who are over than 60 years or older? They say elderly in your book. They've switched it. Now they're trying to make BPC about old people now. They're saying, oh, it's just adults who are 65 years and older. They're not elderly. They're just 65 years young, guys. Strep pneumonia, influenza virus, anaerobes, Haemophilus influenza, and gram-negative rods. Special groups. We have, for alcohol overuse, you can get Klebsiella, true. Anaerobes usually due to aspiration, like Peptostreptococcus, Fusobacterium, Prevotella, and Bacteroides. Injection drug use like strep pneumonia and Staph aureus. Aspiration, like with anaerobes. Atypical pneumonia, we're talking about this mycoplasma pneumonia is atypical pneumonia. Chlamydophila, Legionella, right? Viruses, RSV, CMV, influenza, adenovirus, they can cause atypical pneumonia. Cystic fibrosis, Pseudomonas, Staph aureus, strep pneumonia, Burkholderia cepacia. Again, things that relate CF connected, cystic fibrosis connected. So you would have cystic fibrosis, which is a genetic issue, and then you have an increased risk of these things, which might pop up and lead to a pneumonia, like Pseudomonas, Staph aureus, strep pneumo, and Burkholderia cepacia. What about immunocompromised people? Staph aureus, enteric gram-negative rods, fungi, viruses, P. Girovechi with HIV. What's been healthcare associated? So it'd be like a nosocomial infection. Well, you would have Staph aureus, Pseudomonas, and other enteric gram-negative rods. What about post-viral? Strep pneumonia, Staph aureus, Haemophilus influenza. And what about COPD? Strep pneumonia, Haemophilus influenza, M. catarrhalis. I think that's, let me just make sure that I'm not saying anything incorrectly in reporting that. M. catarrhalis. I know I've M. catarrhalis. Moraxella catarrhalis. Okay. Moraxella catarrhalis, and then Pseudomonas for COPD. What about common causes of meningitis? Common causes of meningitis. Newborns versus children. Okay, let's go talk about newborns 0 to 6 months. What are we thinking? Group B strep, again, strep epigalactiae, E. coli, and Listeria. Listeria monocytogenes, for reference. What about children 6 months to 6 years? Okay. Strep pneumonia, Neisseria meningitidis, H. influenza type B, Group B strep, or again, that's strep epigalactiae, and enteroviruses. Okay. Neisseria meningitidis, be aware of that one, and strep pneumonia, also be aware of that. Those are some big hitting ones. After, for most of your adult life would be strep pneumonia, Neisseria meningitidis are really big targets. Very big candidates for causing meningitis. What about 6 years of age to 60 years of age? That's a pretty unique demographic category. Strep pneumonia, Neisseria meningitidis, enteroviruses, and HSV. So basically very similar category we had before. Strep pneumo still the biggest, and then Neisseria meningitidis, And then we still have enterovirus in there, but we dropped group B strep, and we dropped, now we have HSV added to it as well. And we dropped, we dropped H flu and dropped in group B strep. Now we added an HSV. Okay. What about, and let me just confirm again, I'm doing this many times just for my own sake, perhaps for your sake as well, but for my sake certainly. Herpes simplex virus, I think. Okay. Because when you say HSV1, I know what you're talking about. When you say HSV, I'm like, what are you talking about? Anyway, 60 years and older, so 60 plus, strep pneumo, again, Neisseria meningitidis, again, H flu, now that's back, type B, H flu type B, group B strep, Atelectae, again, and then listeria. So funnily enough, you see kind of a return to some of those older, in people who are older, they start seeing a lot of these earlier problems pop up again. Now you have strep pneumo, and not only do you have strep pneumo again, Neisseria meningitidis, but now you have the older stuff like group B strep and H flu, which you were seeing probably when you were, again, 6 months to 6 years. So again, the biggest things I want to focus on is that basically after 6 months, as they're saying here, the biggest causes of meningitis are going to be things like strep pneumo and Neisseria meningitidis for these sorts of infectious meningitis conditions. These meningitis causes are going to be strep pneumo and Neisseria meningitidis. There are other things like, enteroviruses, for example, HSV for people who are adults, right? And there's some things like H flu, group B strep. Group B strep is a big issue when you're younger. It apparently is also an issue when you're above the age of 65. So be aware of that as well. It says here, give ceftriaxone and vancomycin empirically, add ampicillin if listeria is suspected, add acyclovir if viral encephalitis is suspected. Viral causes of meningitis, enteroviruses, especially Coxsackie virus. So these are bacterial causes as far as I'm aware. Yeah, well, HSV, that's not bacterial, that's viral. And enteroviruses are obviously also viral. Okay, whatever. Ignore that statement. Viral causes of meningitis are enteroviruses, especially Coxsackie virus, HSV2, HSV1 equals encephalitis, HIV, West Nile virus, also causes encephalitis, and VZV. So when they say enteroviruses, they mean all that stuff, basically. Note, the incidence of group B strep meningitis in neonates has greatly diminished due to the screening and antibiotic prophylaxis for pregnancy. Incidence of H. influenza meningitis has greatly reduced due to conjugate H. influenza vaccinations. Today, cases are usually seen in immunized children. Okay. What about cerebrospinal fluid findings in meningitis? We have the opening pressure, cell type, protein, and glucose. So bacterial. This is an important one. Because you'll have questions where they have a vignette for you and they talk about this patient has meningitis and we find XYZ things. You have to figure out what kind of things can you eliminate from your answer choices. So let's say it's bacterial. For bacterial, you have an elevated opening pressure, increased neutrophils, PMNs, increased protein, but decreased glucose. Why? Because the bacteria are eating the glucose. What about fungal? Fungal, you have an increased opening pressure, increased lymphocytes, not neutrophils, lymphocytes, increased protein, and decreased glucose. Why? Because the fungi are eating the glucose. And again, that goes the same is true for TB. What about viral? Viral, you have normal or elevated opening pressure, so you can't really rely on that one necessarily. Elevated lymphocytes, very important, elevated lymphocytes, normal or elevated protein, and then normal glucose. Why? Because viruses are not biologically alive. They do not need glucose to survive. They are not considered a life form in the way that a bacteria would be considered a life form, or fungi would be. So, basically, the easy way for me to phrase it to you is this. If you have elevated neutrophils, you have a bacterial infection. If you have elevated lymphocytes, you have either fungal or viral. For glucose, if it's low, you definitely do not have a virus. Then you definitely do not have a virus. It's either bacterial or fungal. Make sense? So if you have meningitis, you definitely have meningitis right now, let's say, but the glucose is normal, it's a virus. If you have meningitis and you have elevated neutrophils, it's definitely bacterial. If you don't have either of those things, you have elevated lymphocytes but not elevated neutrophils, you have low glucose, then it's fungi. So fungi is kind of like the one that's in between. Fungi have do not have elevated neutrophils, and they do not have normal glucose. Because if their glucose is normal, it's viral. If their neutrophils are high, then it's bacterial. But they have neither. They have elevated lymphocytes, not neutrophils, and they have low glucose, not normal glucose. Well, then it's fungal. Make sense? Anyway. Infections causing brain abscesses. And also bear in mind as well, it's possible that when you have viruses, everything looks kind of normal besides you have high lymphocytes. So it might say, oh, you have high white blood cells, high lymphocytes, but otherwise everything looks relatively normal. Then it's probably a virus. Anyway, infections causing brain abscesses. Most commonly, Viridans, Streptococci, and Staphylococcus aureus. If dental infection or extraction precedes abscess, oral anaerobes commonly involved. Multiple abscesses are usually from bacteremia, single lesions from contiguous sites, otitis media and mastoiditis, leading to temporal lobe and cerebellum, sinusitis or dental infection leading to frontal lobe. Oh, okay, I got it now, okay. Multiple abscesses are usually from bacteremia, single lesion from contiguous sites, otitis media and mastoiditis going to the temporal lobe and cerebellum, while sinusitis or dental infection will go to the frontal lobe. Okay. Toxoplasma reactivation in AIDS. Osteomyelitis. Risk factor versus an associated infection. So osteomyelitis, assume if no other information is available that it's Staph aureus, which is the most common overall. So they don't give you any sort of extra information, probably Staph aureus. If the person is sexually active, think about Neisseria gonorrhea, which is rare, or septic arthritis, which is more common. What about sickle cell disease? Think Salmonella or Staph aureus. Prosthetic joint replacement. Think Staph aureus or Staph epidermidis. Vertebral involvement. Think Staph aureus. Mycobacterium tuberculosis, which is Pasta disease. Yeah, Pasta disease. Cat and dog bites. Think Pasteurella multicida. So Pasteurella for dogs and cats. Injection drug use. Injection drug use. Think Staph aureus, but also Pseudomonas or Candida. Elevated ESR and CRP sensitive but not specific. Radiographs are insensitive early but can be useful in chronic osteomyelitis. And they show a little picture there. I don't know if your book has the same one. No, it's a little bit different. So radiographs are insensitive early but can be useful in chronic osteomyelitis. MRI is best for detecting acute infection and detailing anatomic involvement. Biopsy or aspiration with culture necessary to identify organism. UTIs, urinary tract infections. But actually, I will be going on to red rashes of childhood, so we'll be doing some skipping around perhaps. Wow, these things can be quite nasty. Red rashes of childhood. So we have agent-associated syndrome and disease in a clinical presentation. Coxsackie virus A, associated with hand, foot, mouth disease. Oval-shaped vesicles in palms and soles, shown in the picture in A. Vesicles and ulcers in oral mucosa, herpangina. Human herpes virus 6, HHV6, associated with roseola, which is also called exanthum subidum. Asymptomatic rose-colored macules appear on body after several days of high fever, can present with febrile seizures, usually affects infants. Measles virus, associated with measles or rubeola. Confluent rash beginning at the head and moving downward, shown in the picture B. Oh, for you, no, it's not. Okay. It goes down, preceded by cough, coryza, conjunctivitis, and blue-white Koplik spots on buccal mucosa. What about parvovirus B19? Erythema infectosum, fifth disease. You have slapped cheek rash on the face, and that's in picture B for you. You can see. Rubella virus, associated with rubella, as you can imagine. This is going to have pink macules on the and papules beginning at the head and moving down, remain discrete, leading to fine desquamating truncal rash, post-auricular lymphadenopathy. Okay, what about Streptococcus pyogenes? Associated with scarlet fever. Strep pyogenes, that's group A strep, associated with scarlet fever. Sore throat, circumoral pallor, Group A strep, rash, sandpaper-like, and they show a picture there, I think, for you. Yeah, for picture C for you. Sandpaper rash, sandpaper-like from neck to trunk and extremities, lymphadenopathy, erythrogenic toxin, strawberry tongue, scarlet. So scarlet stands for sore throat, circumpolar pallor, A strep, rash, lymphadenopathy, erythrogenic toxin, strawberry tongue. What about varicella zoster virus? That's VZV. That is what causes chickenpox. Vesicular rash begins on trunk, spreads to face and extremities with lesions of different stages. And then show a picture D for chickenpox. And that later becomes, I believe, herpes zoster. Shingles, that kind of thing. For reactivation, anyways. So that's a different disease presentation, but caused by the same virus. In that case, reactivation of the original virus that you had. Now let's talk about UTIs. UTIs, cystitis presents with dysuria, frequency, urgency, suprapubic pain, and white blood cells, but not white blood cell casts in urine. Primarily caused by ascension of microbes from the urethra to the bladder. Ascension to kidney results in pyelonephritis, which presents with fever, chills, flank pain, costovertebral angle tenderness, hematuria, and white blood cell casts. 10 times more common in females, shorter urethras colonized by fecal microbiota. Risk factors include obstruction like kidney stones, enlarged prostate, kidney surgery, catheterization, congenital GU malformation, and vesico-ureteral reflux, diabetes, pregnancy. What about the different species? So you have the UTI bugs, as your book specifies, with species, features, and comments. Comments are pretty broad, so I'll just read each one out as it is. Escherichia or E. coli. Features. Leading cause of UTI, number 1. Colonies show strong pink lactose fermentation on MacConkey agar. Staphylococcus saprophyticus, that's number 2. Second leading cause of UTI, particularly in young, sexually active females. Klebsiella pneumonia, that's the third leading cause of UTI, largely mucoid capsule and viscous colonies. What about Serratia maricens? And with Klebsiella, by the way, you can get it because they have catheterization at a hospital, for example. Serratia maricens. Some strain patterns produce a red pigment, often healthcare associated and drug resistant. Serratia. Enterococcus, often healthcare associated and drug resistant. Proteus mirabilis. Motility causes swarming on agar, associated with struvite stones, produces urease. It's urease positive. Pseudomonas aeruginosa is a blue-green pigment with fruity odor, usually healthcare associated and drug resistant. Bear in mind the blue-green pigment is because it has pyoverdin and pyocyanin pigments. Comments in general. Diagnostic markers. Positive leukocyte esterase, which would be evidence of a white blood cell activity. Positive nitrite test. Reduction of urinary nitrates by gram-negative bacteria species like E. coli. So if you have, for example, a lot of nitrites, you take a nitrite test, you realize that there's nitrates being made from the nitrates you would have. That means there's some sort of bacterial activity going on because they're causing that reaction to occur. And your book has another thing that says urease test, positive urease test, urease producing bugs like Saprophyticus, Proteus, and Klebsiella. Yeah, true. Remember, those species are urease positive. I'm not sure why they didn't add that in there, but in my textbook edition, maybe they don't think it's important anymore, but whatever. Common vaginal... That looks gross. Anyway, common vaginal infections. So we have signs and symptoms, lab findings, and treatment. So what about bacterial vaginosis? No inflammation, thin, white discharge, you can see in the picture in A, with fishy odor. Yeah, that does not sound particularly pleasant. Lab findings. Clue cells, bacteria-coated epithelial cells, pH is greater than 4.5. Positive potassium hydroxide whiff test. Treatment would be metronidazole or clindamycin. Okay, so bear that in mind. What about trichomonas vaginitis? Different presentation. Inflammation with a strawberry cervix, a frothy, yellow-green, foul-smelling discharge. Lab findings would be a motile, pear-shaped trichomonads. You can see that picture in B for your book. pH is greater than 4.5. That's important to be aware of as well. The metronidazole, you treat the Trichomonas vaginalis with metronidazole, and you also want to treat sexual partners. Again, I think I mentioned this in the last video stream. It's not as notable in men. Men are not usually as symptomatic, and as a consequence of that, if this is a situation where they have this person, because it is an STI, is getting infections from some other person in their life, they should also probably get tested and treated because they probably also have it, even if they are male and they don't have to necessarily have symptoms. Okay. Anyway, but Trichomonas vaginitis, that is a parasite technically. That is not a bacteria. That is a parasite. It is a protozoan. What about Candida vulvovaginitis? Candida will have inflammation, thick white cottage cheese discharge. It is very unpleasant. Okay, pseudohyphae. pH would be normal though, 4.0 to 4.5. How do you treat Candida? With azoles, which makes sense because azole types are antifungal. So again, bacterial vaginosis is bacterial. Treat metronidazole. Trichomonas vaginitis, that's the strawberry cervix. That's going to be protozoan with a yellow-green foul-smelling discharge. And then Candida vulvovaginitis, that's the white cottage cheese discharge. That's going to be a fungal infection. None of those sound particularly great, but they do happen. So, sexually transmitted infections, we'll go into that soon. We can find the page on it. This is a torches infection thing. I think torches is important. If I don't know if this is in my book or not, but it's in my book, so we'll get to it when we get to it. Sexually transmitted infections. Here we go. These are not going to be pretty either. A lot of penises in my book, apparently. Okay. Sexually transmitted infections. The disease, clinical features, and the pathogen. So the disease, AIDS. I'm not sure if you've heard of that one before. AIDS, features would be opportunistic infections, Kaposi sarcoma, lymphoma. Its pathogen would be HIV. You probably have heard of that one before. Cancroid. Cancroid, what causes it? It's a painful genital ulcer with exudate inguinal adenopathy. Again, painful cancroid caused by Haemophilus ducreyi. Again, this is not a bad one to remember for a learning device. It's so painful that you cry because it's ducreyi, and it's a painful cancroid. Now, chlamydia, the disease, will cause urethritis, cervicitis, epididymitis, conjunctivitis, and reactive arthritis and PID. The pathogen would be chlamydia trachomatis, which is D through K. Condylomata acuminata. Clinical features would be genital warts, which you can see, I think, your book doesn't have it, but whatever. Genital warts and coilocytes for Condylomata acuminata. It's caused by HPV 6 and 11. Herpes genitalis. Painful, penile, vulvar, or cervical vesicles and ulcers. Yes, ulcers with bilateral tender inguinal lymphadenopathy can cause systemic symptoms such as fever, headache, and myalgia. Pathogen is HSV2, less commonly HSV1. We talked about it in the last stream that HSV2 is naturally adapted to being an STD, basically. It's a virus it's accustomed to the genital region, while HSV1 is accustomed to the oral region, which is why HSV1 is traditionally called oral herpes and HSV2 traditionally called the genital herpes virus, informally kind of. The problem is that there isn't anything that necessarily prevents one of those viruses from going to the other region, barring people simply not putting one place in the other area. But because there's more of that going on, you see more and more people getting HSV1 in the genital region because of you know what, right? So, and basically, most people have HSV1. Most people do not have HSV2. They do not. Most people do not have HSV2. But most people do have HSV1 because they're not getting it as STD. They're getting it as basically from saliva contact or some other kind of physical contact with people that's not necessarily sexual. And they're getting oral herpes. Most people have oral herpes in the United States and other countries. And so most people have oral herpes from non-sexual reasons, and they're doing something with somebody else in a different part of the body. They can give them genital herpes without even necessarily getting it genital herpes from some other person. So just bear that in mind. So you're seeing HSV2 still predominant, but you're seeing more and more cases of HSV1 as a form of genital herpes. Gonorrhea. Gonorrhea causes urethritis, cervicitis, PID. But when we say PID, we mean pelvic inflammatory disease. Prostatitis, epididymitis, arthritis, creamy purulent discharge caused by Neisseria gonorrhea. Granuloma inguinale, Donovanosis. So granuloma inguinale, painless, beefy red ulcer that bleeds readily on contact, which you can see in the picture there, is uncommon in the United States. It's caused by Klebsiella, which is Calamatobacterium, granulomatis, cytoplasmic Donovan bodies, bipolar staining, seen on microscopy. What about Hep B? Hepatitis B causes jaundice, and it's caused by hepatitis B virus, HBV. Lymphogranuloma venereum, infection of the lymphatics, painless genital ulcers, painful lymphadenopathy, i.e. buboes, caused by chlamydia trachomatis L1 through L3. Remember, L1 and L3 affects the lymph nodes that are inguinal. So where were we? So primary syphilis. This is all about, we're going to go into syphilis right now. So primary syphilis, painless canker, regional lymphadenopathy. Remember, primary syphilis, it's a painless canker. Compare that to Haemophilus ducreyi, which causes a painful cancroid. So painful cancroid, Haemophilus ducreyi, and painless canker, think syphilis, think Treponema pallidum. What about secondary syphilis? Secondary syphilis, fever, diffuse lymphadenopathy, generalized rash, condylomata lata. What about tertiary syphilis? Tertiary syphilis, gummas, tabes dorsalis, general paresis, aortitis, and Argyll-Robertson pupil. So basically, just be aware there's different stages. There's a primary, secondary, and tertiary. Tertiary is pretty nasty. We have gummas, tabes dorsalis, aortitis, Argyll-Robertson pupil, you have neurosyphilis, right? Nasty, nasty stuff. But even primary, just be aware there's a stage process for that, and that's caused by Treponema pallidum. Treponema pallidum is the cause of syphilis. What about trichomoniasis? Trichomoniasis, vaginitis, strawberry cervix, motile and wet prep, caused by the Trichomonas vaginalis protozoan. My book has a lot more pictures of penises. Let me count them out. 1, 2, 3, 4 different kinds of penises with different kinds of lesions on them. One of them just looks messed up. I don't know what's going on. What is E? Bubos. Okay. Oh, there's a bubos on the side of the leg in that sort of inguinal region. As we were talking about before, we're talking about lymphogranuloma venereum. So there's 4 penises and there's 2 other things going on. So I guess they felt the more penises the better, I suppose, for the newer edition. I'm not quite sure what's going on with that. I'm not sure how much you're going to see in terms of that on the exam. I'm not sure if they're going to show you a picture of a penis and they're going to say, what kind of infection is that? Maybe they will. It's relevant. Like if you have a patient in the, in the hospital and they say, hey, what's this? You got to know what's going on, right? So anyway, we're going to go to torch infections now. Torch infections. Microbes that may pass from the mother to the fetus. Transmission is transplacental in most cases, or via vaginal delivery, especially HSV2. Non-specific signs common linked to many torches infections include hepatosplenomegaly, jaundice, thrombocytopenia, and growth restriction. Other important infectious agents include Streptococcus agalactiae, i.e. group B streptococci, E. coli, and Listeria monocytogenes. All causes of meningitis in neonates. So what they're saying is, even if it's not a torch infection because it's not transplacental, it might still you might still have a kid who gets one of these other infections because they might get it from vaginal delivery. That's what I'm getting from. Group B strep is like that. Group B strep is like that. I think Listeria is like that. Parvovirus B19 causes hydrops fatalis. That's nasty. That's a terrible thing to have. Toxoplasma gondii. So we're going to talk about maternal acquisition, maternal manifestations, and neonatal manifestations. And, of course, the actual agent. So Toxoplasma gondii, you can see a picture there for you. Its maternal acquisition is cat feces or ingestion of undercooked meat. The mother will present with usually asymptomatic and potentially lymphadenopathy in some rare cases. And for the neonatal manifestations of Toxoplasma gondii, classic triad of chorioretinitis, hydrocephalus, and intracranial calcifications, plus or minus the blueberry muffin rash. And you can see a picture of that rash in A, picture A. Rubella. Rubella will be acquired by the mother through respiratory droplets. She might have a rash, lymphadenopathy, polyarthritis, and polyarthralgia. The child will present with a classic triad of abnormalities of the eye, cataracts, and ear deafness, and congenital heart disease, PDA, plus or minus blueberry muffin rash, I, this is a little mnemonic here, love, ruby, rubella, earrings. Whatever, man. Just remember that it causes PDA and deafness and cataracts for kids. Not fun. Cytomegalovirus, CMV. Spread to the mother via sexual contact and organ transplants. It might react, if you're having an organ transplant, maybe you might have to have like a immunosuppression, so it might reactivate or something like that. If I'm not mistaken, that's how it happens. But whatever, CMV, sexual contact organ transplants, might present with they might be usually asymptomatic, but they might have a mononucleosis-like illness. So it will present like mononucleosis, but it'll be heterophile negative, unlike EBV, which will be heterophile positive. So CMV, for the kid with CMV, it'll present with hearing loss again, seizures, petechial rash, blueberry muffin rash, chorioretinitis, paraventricular calcifications. And so CMV of chorioretinitis, microcephaly, and paraventricular calcifications. That one's not too bad. CMV, chorioretinitis, microcephaly, paraventricular calcifications. Fair enough. Again, you see some overlap with symptoms, things like blueberry muffin rash, calcifications like you saw back of toxo. You see chorioretinitis, which is also like toxo. So there's some overlap in some of the symptoms you might see. What about HIV? HIV from sexual contact or needle stick. Mother will present variable presentation depending on the CD4 count. And with neonatal manifestations, you'll see recurrent infections and chronic diarrhea. What about herpes simplex 2 virus? Herpes HSV2, herpes simplex virus 2. You might get it from skin or mucosal membrane contact for the mother. I mean, let's be honest, it is an STD typically. So when you say skin or mucous membrane contact, yeah, but what mucous membranes are we talking about here, okay? What kind of skin contact are we talking about? It's usually, a lot of times it's sexual, right? For HSV2. Usually asymptomatic herpetic vesicular lesions. Meningoencephalitis, for the child will present with meningoencephalitis, herpetic vesicular lesions. Not good. What about syphilis? Syphilis, let's go down a little bit. It's spread by sexual contact. You have a primary canker and disseminated rash secondary, and are the two stages likely to result in fetal infection. Often results in stillbirth. Ugh, that's terrible. Hydrops fatalis likewise, right? The kid doesn't make it. If the child survives, presents with facial abnormalities like a notched teeth, which is I think Hutchinson's teeth, saddle nose, rhinitis, short maxilla, saber shin, cranial nerve 8 deafness. So you have like a deafness from the actual nerve issue. Pretty terrible stuff. And that's syphilis, right? Now syphilis, I think those notched teeth are called Hutchinson teeth. Hutchinson teeth? Am I right? Hutchinson teeth are specifically dental abnormality caused by congenital syphilis. So I'm right about that. They might not call it that on the exam, but that's one of the things. That's the name that they give for it. Now let's talk about pelvic inflammatory disease, PID. Pelvic inflammatory disease, ascending infection causing inflammation of the female gynecologic tract. PID may include salpingitis, endometritis, hydrosalpinx, and tubo-ovarian abscess. Signs include cervical motion tenderness, adnexal tenderness, purulent cervical discharge. Top bugs would be chlamydia, trachomatis, like subacute, often undiagnosed, Neisseria gonorrhea, acute. Chlamydia trachomatis, most common bacterial STI in the United States. Salpingitis is a risk factor for ectopic pregnancy, infertility, chronic pelvic pain, and adhesions. Can lead to perihepatitis, Fitzhugh-Curtis syndrome, infection and inflammation of liver capsule, and violin string adhesions of peritoneum to liver. Okay. Now, your book says nosocomial infections, which is what I've heard of it as. They say healthcare-associated infections. It's the same idea, basically. E. coli, UTI, and Staph aureus wound infection are the two most common causes. Risk factor, pathogen, unique signs and symptoms. So antibiotic use, PPIs. So antibiotic use and proton pump inhibitors, you might have Clostridium difficile. Unique signs and symptoms, watery diarrhea, leukocytosis. So again, risk factor, aspiration, secondary to altered mental status, old age. You might have a pathogen like polymicrobial, gram-negative bacteria, often anaerobes. And you might have a right lower lobe infiltrate or right upper middle lobe, patient is recumbent, purulent malodorous sputum. Okay. What if you're doing your decubitus ulcers, surgical wound drains? Decubitus ulcers, surgical wounds, and drains. What about that? Well, you could get Staph aureus, including MRSA, not fun. Gram-negative anaerobes like Bacteroides, Prevotella, and Fusobacterium. Unique signs would be erythema, tenderness, induration, drainage from surgical wound sites. Intravascular catheters. You could get Staph aureus, including MRSA, again, Staph epidermidis, long-term. You can get, this will present maybe with an erythema, induration, tenderness, drainage from access sites. What about mechanical ventilation, endotracheal intubation, with late onset with Pseudomonas aeruginosa, Klebsiella, Acinetobacter, and Staph aureus? You might present with a new infiltrate on chest x-ray, increased sputum production, sweet odor, Pseudomonas. Exposure to blood products, shared medical equipment, needle sticks, HPV, HCV. Okay. Urinary catheterization. This is something they have in here. Proteus species, like Proteus mirabilis, E. coli, and Klebsiella, PEC. So again, that's Proteus, E. coli, Klebsiella, PEC. Dysuria, leukocytosis, flank pain, or costovertebral angle tenderness. That's CVA tenderness. So how that works is this. As from my understanding, let's say a patient is sitting down, and you're behind them, and you put your hand, you do Lloyd's punch. You can look up Lloyd's punch, LLOYDS, Lloyd's punch. And you put your hand on the side where their kidney would kind of be in that sort of CVA region. And then you kind of put your hand flat on there, and then you kind of give it up with your other hand. Put your other hand in a fist and kind of tap it or hit it a little bit. Don't be too harsh, but and if they have a lot of pain from that side, they might have something wrong with their kidney. It might be like a pyelonephritis, so like an infection, or maybe a hydronephrosis, or maybe a nephrolithiasis, like a kidney stone. But something might be going wrong with the kidney in that case. So that's CVA tenderness, that's Lloyd's punch. And that can be an issue potentially for somebody who has a UTI from urinary catheterization from Proteus or E. coli or Klebsiella. What about water aerosols? Legionella. Signs of pneumonia, GI symptoms like diarrhea, nausea, vomiting, neurologic abnormalities. Bugs affecting unvaccinated children. Let's talk about it. Unvaccinated children. Now, they say unvaccinated children. It should be said as well that if you're an adult and you're not vaccinated for something in particular, there's nothing magical about being an adult that prevents you from getting that disease. So let's say, for example, let's say I go to a country in Central Africa and I'm not vaccinated for some sort of strange disease that's kind of specific or endemic to Central Africa. I can still get the disease because I'm not vaccinated for it if I didn't get my vaccination for that disease, right? Obviously. If you have people who immigrate to the United States or other countries and they simply do not have the same sort of vaccination regimen as the United States does, there's nothing that stops them from not getting that disease, right? And the bigger issue is that when you compare that to, for example, let's say somebody says, oh, I read on Facebook that if you get vaccinated for whatever, your kid's going to, I don't know, grow a third leg or something like that, whatever, and they don't get their kid vaccinated. You can make the argument for that's kind of an issue in a certain sense because you want to have herd immunity. But realistically speaking, if that's a low-level issue for individuals doing this kind of stuff, it's usually not too dangerous when it's at a low level. It's not really necessarily problematic per se in terms of functional effect. However, if you have a group of people in a particular location that does not get vaccinated for something, then that could present an issue because none of the people in that community are getting vaccinated for, and therefore you have an area that could be a reservoir for that disease. And so if you have somebody, for example, let's say we bring in 100,000 people from a particular region of the world, and you have a different vaccine regimen from that country, they might have that disease. There might be a reservoir for that disease, and if they're not getting vaccinated for it, then they could wind up spreading that disease to that local area, to people who are the minority who are of the country who are not vaccinated, and to people who are within their own community who are not vaccinated for it but don't have it otherwise. So it's kind of a complicated subject, I guess you could say. It's not just kids, for reference. Anyway, clinical presentation, findings in labs, pathogen. So dermatologic, rash. Beginning at the head and moving down with post-auricular, posterior cervical, and suboccipital lymphadenopathy. Pathogen would be rubella virus. The other rash would be beginning at the head, beginning at the head and moving down, preceded by cough, coryza, conjunctivitis, and Koplik spots. What are you thinking? Measles, of course, right? What about neurologic? This is not fun. Meningitis. Microbe colonizes the nasopharynx. What do you think? H. influenza, type B. Okay. What about can also lead to myalgia or paralysis? Ooh. Poliovirus. That's not fun. What about tetanus? Tetanus toxin. Let's talk about tetanus. Muscle spasms, spastic paralysis, tetanic paralysis, spastic paralysis. Lockjaw opistotonus. What are we thinking? Tetany. We're thinking about Clostridium tetany. What about respiratory issues? Respiratory. Let's say I have epiglottitis. Fever with dysphagia, difficulty eating, pain with eating, drooling, inspiratory stridor, difficulty breathing due to edema. What do we think? H. influenza type B, also capable of causing epiglottitis in fully immunized children. Well, that's an important detail. Yeah, so apparently it can cause epiglottitis in fully immunized children. Can, okay. Pertussis. Low-grade fever, coryza leading to whooping cough. Post-tussive vomiting leading to gradual recovery. Bordetella pertussis. And for Bordetella pertussis, they have an acellular vaccine for that. What about pharyngitis? Pharyngitis, grayish through the membranes, may obstruct airways, Corynebacterium diphtheria. Yeah, your book is a little bit more specific on that. So it may obstruct airways, painful throat, and it says elaborates toxin that causes necrosis in pharynx, cardiac, and CNS tissue. Okay. And here's something. Oh, this is actually, I like this a little bit. My book doesn't have this, unfortunately. It says here, characteristic organisms, bug hints if all else fails. Well, that'd be nice to have in my book, but they took it out. You would think the rapid review, high yield stuff they would leave in. Apparently not. They think it's a little bit too redundant. But let's see, characteristics in organism. This is a little bit of a guessing game. Think about it, okay? Asplenic patient due to surgical splenectomy or autosplenectomy, chronic sickle cell disease. What do we think? Encapsulated microbes, especially Shin, strep pneumonia more than anything else, but also H. flu, type B, and Neisseria meningitidis. Okay. What about branching rods and oral infection, sulfur granules? Actinomyces israelii. So think about you're in the Israeli desert, and it's got this sort of sulfury, yellowish granule sand. Chronic granulomatous disease, CGD. What do we think? Calyx-positive microbes, especially Staph aureus. There's more than just Staph aureus, but that is definitely one of them, yes. Current jelly sputum. What do we think? Klebsiella, of course. Dog or cat bite. A good candidate for that would be Pastorella multicida. Let's see. Facial nerve palsy. Typically bilateral. What do we think? Borrelia burgdorferi, Lyme disease. Fungal infection in diabetic or immunocompromised patient. What do we think? Mucor mucormycosis, for example, mucor, or rhizopus species. Healthcare provider, nosocomial. What do we think? HPV from needle stick. Neutropenic patient. What do we think? Candida albicans, systemic or aspergillus. Organ transplant recipient, we think cytomegalovirus. PAS positive, tropharema, Whipple disease. Pediatric infection, Haemophilus influenzae, including epiglottitis, yes. Pneumonia and cystic fibrosis, burn infection. What do we think? Pseudomonas aeruginosa. Yeah, that's a good one. Pus. Well, I mean, obviously not good to have, but it's a good association to know. Pus, empyema, abscess, Staph aureus. Rash on the hands and the feet. What do we think? Coxsackie virus A, or Trypanosoma pallidum, or Rickettsia. Couple different things. Sepsis / meningitis in newborn. What do we think? Group B strep. Surgical wound. Think Staph aureus. For traumatic open wound, think about Clostridium perfringens. Now we'll be going on to the next section called the Microbiology Antimicrobial section, i.e. the pharmacology section for this chapter. We're on page 183. We'll wrap up on 199. So I'm going to go take a break, and I'll come back to you. If you're watching a recording of this, just skip forward to the point where I'm start talking again, okay? Thank you. Okay, we are back, and we're going to the antimicrobial section, which is the last section, section 7 of the microbiology textbook. We're on page 183. We're up on page 199. It'll probably be maybe about an hour and a half or something like that to complete this section, I would assume. So with that out of the way, let's get to it. Antimicrobials. We start with this antimicrobial therapy chart, which you may have been reading while I was away, perhaps, I don't know. It's a good chart. You should take a picture of it, and you should put it in your notes if you want to. I like it. It has different things on it: folic acid synthesis and reduction, talking about sulfonamides, some of the thoxazole, sulfadiazine, trimethoprim. You remember integrity, peptidoglycan synthesis, peptidoglycan cross-linking. We have 30S subunit stuff, so like aminoglycosides. We have things like 50S subunit, things that mess with that, so things like macrolides and streptogramins. We have gyrase, things like fluoroquinolones. We have things like rifampin, messing with mRNA synthesis, and then things that mess with DNA integrity like metronidazole. So it's very, very comprehensive. It's actually not, it has a lot of detail to it, although it's not as detailed as you might want to be in theory for some of this stuff. So it's really a good review slide. If you're, for the most part, familiar with these drugs, it's a very good way to review all of them in a relatively, expedient amount of time. I like it. I like it. It's not perfect, but it's useful. Or can be useful. So let's talk about penicillin G and V. Penicillin G, IV and IM form. Penicillin V, oral. Prototype beta-lactam antibiotics. Mechanism: D-ala-D-ala structural analog. Binds the penicillin binding proteins, transpeptidases. Blocks the transpeptidase cross-linking of peptidoglycan and cell wall. Activates the autolytic enzymes. Clinical use: mostly used for gram-positive organisms like Strep pneumonia, Strep pyogenes, and actinomyces. Also used for gram-negative cocci, mainly Neisseria meningitidis, and spirochetes, mainly Treponema pallidum. Bactericidal for gram-positive cocci and gram-positive rods, gram-negative cocci, and spirochetes. Beta-lactamase sensitive, though. And your book says penicillinase sensitive. Same idea. Adverse effects: hypersensitivity reactions, direct Coombs positive hemolytic anemia, drug-induced interstitial nephritis. Resistance: beta-lactamase cleaves, they say penicillinase. So, beta-lactamase cleaves the beta-lactam ring, true. Mutations in PBPs. And that's why if you're taking penicillin G, you might want to take something like an additional drug which blocks penicillinase or blocks the beta-lactamase. I'm trying to think of a good drug that's like sulbactam, maybe. What are some beta-lactamase inhibitors? Let's see. Examples. Can I get some examples? They say sulbactam. I'm seeing sulbactam, tazobactam, avibactam, relebactam. So sulbactam and those kinds of things, tazobactam, those are drugs you can take with penicillin G or V if you're trying to avoid the resistance via penicillinase or beta-lactamases. They can have things like beta-lactam ring mutations. They can also have mutations in the PBPs, which will help inhibit that effect. This could be completely sidestepped, I believe, by vancomycin, which affects the same D-ala-D-ala system, but doesn't do the same thing, does something different. It messes with the D-ala-D-ala directly. Is it mentioned in here? Yeah, vancomycin, it says glycopeptides, vancomycin, bacitracin. What about penicillinase-sensitive penicillins? Let's talk about it. Amoxicillin, ampicillin, aminopenicillins. Mechanism: same as penicillin, wider spectrum, penicillinase activity, also combined with clavulanic acid to protect against destruction by beta-lactamase. Aminopenicillins are amped up penicillin. Amoxicillin has a greater oral bioavailability than ampicillin. Okay. Clinical use: extended spectrum penicillin, H. influenza, H. pylori, E. coli, enterococci, Listeria monocytogenes, Proteus mirabilis, Salmonella, Shigella. The coverage: ampicillin/amoxicillin helps kill enterococci. The adverse effects: Hypersensitivity reactions, rash, pseudomembranous colitis. Mechanism of resistance, penicillinase, a type of beta-lactamase, cleaves beta-lactam ring. What about penicillinase-resistant penicillins? Dicloxacin, nafcillin, oxacillin. The mechanism, same as penicillin, narrow spectrum. Penicillin resistant because bulky R group blocks access to a beta-lactamase to beta-lactam ring. Clinical use. Staph aureus except MRSA. Adverse effects. Hypersensitivity reactions, interstitial nephritis. And also, by the way, when it comes to the clinical use, Staph aureus except MRSA, it says here, use NAF for staph. Nafcillin for staph. Okay. What are the mechanisms of resistance, though, for this type? MRSA has altered penicillin binding protein target site, so this will still have some resistance in this case. What about piperacillin? Piperacillin, which I don't think I even see it on your thing. Oh, see it right there. It says anti-pseudomonal penicillins. Yeah, piperacillin is good for Pseudomonas. Piperacillin, in your book says along with that ticaracillin, or ticaracillin, but piperacillin is an anti-pseudomonal penicillin. Mechanism, same as penicillin, extended spectrum, penicillinase sensitive, used with beta-lactamase inhibitors, as we were talking about before, tazobactam, sulbactam. Clinical use, Pseudomonas species, gram-negative rods, anaerobes. Adverse effects, hypersensitivity reactions. What about cephalosporins? Cephalosporins, right here, 1 through 4. Cephalosporins, these are a little bit more heavy duty overall, and then they have their own kind of classification system. Cephalosporins mechanism, beta-lactam that inhibits the cell wall synthesis, but are less susceptible to penicillinases. They are bactericidal. Organisms typically not covered by the 1st through 4th generation cephalosporins are lame, Listeria, atypicals, chlamydia, mycoplasma, MRSA, and enterococci. So those species, Listeria, atypicals like chlamydia, mycoplasma, MRSA, enterococci, those species are not covered by the 1st through 4th generations of cephalosporins. So bear that in mind. What about clinical use? First generation cephalosporins, that is to say cefazolin and cephalexin, are gram-positive cocci, Proteus mirabilis, E. coli, Klebsiella pneumonia. Cefazolin used prior to surgery to prevent Staph aureus wound infections. First generation, positive PEC. Second generation, cefaclor, cefoxitin, cefuroxime, cefotetan. Gram-positive cocci, H. influenza, Enterobacter origines, Neisseria species, Serratia maricens, Proteus mirabilis, E. coli, Klebsiella pneumonia. It says here that as a learning device, second graders wear fake fox fur to tea parties. Second generation, positive hens peck. Okay. What about third generation? This one's going to be a very, very well-known one. Ceftriaxone, very important. Cefpodoxime, ceftazidime, and cefexime. Serious gram-negative infections resistant to other beta-lactams. Can cross blood-brain barrier. Ceftriaxone treats meningitis, gonorrhea, disseminated Lyme disease. Very important, by the way. Ceftazidime for Pseudomonas. Okay. Fourth generation. Cefepime, gram-negative organisms with elevated activity, increased activity against Pseudomonas and gram-positive organisms. Fifth generation, ceftaroline, broad gram-positive and gram-negative organism coverage. Unlike the 1st through 4th generation cephalosporins, ceftaroline covers MRSA and Enterococcus faecalis, but does not cover Pseudomonas. Interesting. What about adverse effects? Hypersensitivity reactions, autoimmune and hemolytic anemia, disulfiram-like reaction, vitamin K deficiency, low rate of cross-reactivity even in penicillin-allergic patients, elevated nephrotoxicity of aminoglycosides. The mechanism of resistance, it says inactivated by cephalosporinases, a type of beta-lactamase. Okay, structural change in penicillin-binding proteins like transpeptidases. So if they can actually just change the actual penicillin-binding protein in the first place, and now make it more difficult for it to actually counter it, essentially. what about beta-lactamase inhibitors? So we were talking a lot about beta-lactamases, cephalosporinases, penicillinases, these kinds of things. What about the beta-lactamase inhibitors? What can counteract the beta-lactamases? This includes clavulanic acid, avibactam, sulbactam, tazobactam, often added to penicillin antibiotics to protect the antibiotic from destruction by beta-lactamase. The learning device is CAST, amoxicillin clavulanate, ceftazidime, amoxicillin clavulanate, ceftazidime, avibactam, ampicillin sulbactam. These are like combos. Ampicillin sulbactam and piperacillin tazobactam. If I were you, just know this. The bactam is this kind of suffix that they use for a lot of these beta-lactamase inhibitors. There's some exceptions to that rule, like clavulanic acid, for example. But for the most part, they're called sulbactam, tazobactam, avibactam. Because they're what? Beta-lactamases. So beta-lactamases are bactams. So just be aware of that. So when they bring up the name, or they see it as an answer choice, just be aware of what it does. So now we're in carbapenems. Oh, we're going to go into vanco and everything. Okay. Carbapenems. We have imipenem, meropenem, ertapenem. The mechanism: imipenem is a broad-spectrum beta-lactamase-resistant carbapenem. Binds penicillin-binding proteins, leading to inhibition of the cell wall synthesis, leading to cell death. Always administered with cylostatin, inhibitor of the renal dihydropeptidase 1, to decrease the inactivation of drug in renal tubules. With imipenem, the kill is elastin with cylostatin. Unlike other carbapenems, ertapenem is not active against Pseudomonas. What about clinical use? Gram-positive cocci, gram-negative rods, and anaerobes. Wide spectrum and significant adverse effects. Limit use to life-threatening infections or after other drugs have failed. Meropenem have a decreased risk of seizures and is stable to dihydropeptidase 1. Okay. What about the adverse effects? GI distress, rash, and CNS toxicity like seizures at high plasma levels. The mechanisms of resistance? Well, inactivated carbapenemases produced by, for example, Klebsiella pneumonia, E. coli, and Klebsiella aerogenes. So the bacteria, very, very impressive what they're able to pull off. They have these carbapenemases, these penicillinases, very impressive. Something to be aware of as well, these sorts of resistance mechanisms. What about astrionam? Astrionam, which I don't know if you have in your thing or not. Yeah, they say monobactam. Astrionam, which is a monobactam mechanism, less susceptible to beta-lactamases, prevents peptidoglycan cross-linking by binding to the penicillin-binding protein 3, synergistic with aminoglycosides, no cross-allergenicity with penicillins. The clinical use, gram-negative rods only, no activity against gram-positive rods or anaerobes, for penicillin-allergic patients and those with renal insufficiency who cannot tolerate aminoglycosides. The adverse effects, usually non-toxic, occasional GI upset. What about vancomycin? Vancomycin, the mechanism, inhibits cell wall peptidoglycan formation by binding to the D-ala portion of the cell wall precursors, bactericidal against most bacteria, bacteriostatic against C. difficile, not susceptible to beta-lactamases. Clinical use for vancomycin, gram-positive bugs only, for serious multi-drug-resistant organisms including MRSA, Staph epidermidis sensitive Enterococcus species, and C. difficile, oral route. The adverse effects? Well tolerated in general, but not trouble-free. Nephrotoxicity, ototoxicity, thrombophlebitis, diffuse flushing, vancomycin infusion reaction, which you can see in picture A. Idiopathic reaction largely preventable by pre-treatment with the antihistamines and slower infusion rate, DRESS syndrome. Mechanism of resistance occurs in bacteria like Enterococcus via amino acid modification of the D-ala to D-ala-D-lac. So that's D-ala-D-lac, lac. Pay back $2 for vandalizing vancomycin. Or in my book it says, if you lack a D-ala dollar, you can't write on the van vancomycin. So they switch the D-ala to D-lac, and that prevents it for that methodology. So in this case, vancomycin kind of sidesteps the whole penicillin problem because the penicillins and cephalosporins and these kinds of things, these beta-lactams, they can be knocked out by beta-lactamases, theoretically. But with vancomycin, they sidestep that completely. They still work on the same mechanism, but they're working by attaching to the diala. But then they can sidestep it by messing with the dialysis. So there's different ways that the bacteria can figure out how to counter these drugs. And of course, the bacteria are not conscious. They're not, going to the drawing board per se. But there's adaptation, seemingly. Protein synthesis inhibitors. So protein synthesis inhibitors specifically target smaller bacterial ribosomes 70S made of 30S and 50S subunits, leaving human ribosome 80S unaffected. All are bacteriostatic except aminoglycosides, bactericidal, and linezolid, variable. The 30S inhibitor, aminoglycosides, and tetracyclines. It says here, buy at 30, sell at 50. Okay, that's just a little mnemonic for you if you want to use that. I don't care for it, really. But aminoglycosides and tetracyclines, buy at 30, sell at 50. Okay. 50S, it says chloramphenicol, clindamycin, erythromycin, macrolides, and linezolid. So the ones that are 50S, are going to be chloramphenicol, clindamycin, erythromycin, linezolid. Those are 50S. But the ones that are 30 are aminoglycosides and tetracyclines. That's why they say ATCCEL, that kind of thing. What about, there's a little picture right there for you to look at if you want to. Gives you a diagram of how that stuff works. I have my own diagram, which is a little bit different. But just be aware that the locations that some of these 50S and 30S are working are actually different locations. Even they say, oh, this is 30S, this is 50S. It is technically different places of the cycle. Aminoglycosides. Aminoglycosides, gentamicin, neomycin, amikacin, tobramycin, streptomycin, mean aminoglycosides, gnats, cannot kill anaerobes. Okay. Mean gnats cannot kill anaerobes. Mechanism. Bactericidal irreversible inhibition of the initiation complex to the binding of the 30S subunit can cause misreading of mRNA, also block the translocation, requires O2 for uptake, therefore ineffective against anaerobes. The clinical use, severe gram-negative rod infections, synergistic with beta-lactam antibiotics, neomycin for bowel surgery. The adverse effects, nephrotoxicity, neuromuscular blockade, absolute contraindication with myasthenia gravis, ototoxicity, especially with loop diuretics, teratogenicity. The mechanism of resistance for aminoglycosides, bacterial transferase enzymes inactivate the drug by acetylation, phosphorylation, or adenylation. Okay, now we're on to tetracyclines. Tetracycline, doxycycline, minocycline. The mechanism. While it's bacteriostatic, binds to the 30S and prevents attachment to the aminoacyl tRNA, limited CNS penetration. Doxycycline is fecally eliminated and can be used in patients with renal failure. Do not take tetracyclines with milk, calcium, antacids, calcium or magnesium, or iron-containing preparations because divalent cations inhibit drugs absorption in the gut. Clinical use for tetracyclines. Borrelia burgdorferi, mycoplasma pneumonia, drugs' ability to accumulate intracellularly makes them very effective against rickettsia and chlamydia. Also used to treat acne. Okay. Doxycycline effective against community-acquired MRSA. The adverse effects of tetracyclines: GI distress, discoloration of teeth, and inhibition of bone growth in children. Photosensitivity. Teratocyclines are teratogenic. It's called tetracycline, but you get the idea. They're trying to say it a certain way. It's teratogenic, generally avoided in pregnancy and in children except doxycycline. Mechanism of resistance: decreased uptake or increased efflux out of bacterial cells by plasmid-encoded transport pumps. What about tiglicycline? Tiglicycline, which is a glycylcycline, it's going to be, mechanism is tetracycline derivative, binds to the 30S, inhibiting the protein synthesis, generally bacteriostatic. Clinical use for tiglicycline: broad spectrum anaerobic gram-negative and gram-positive coverage, multi-drug resistant organisms like MRSA and VRE. VRE, I think, it's vancomycin resistant something. VRE bacteria. vancomycin-resistant enterococci. Adverse effects of tigecycline, nausea and vomiting. What about chloramphenicol? Mechanism: blocks the peptidyltransferase at 50S ribosomal subunit, bacteriostatic. Clinical use for chloramphenicol: meningitis, H-flu, Neisseria meningitidis, Streptococcus pneumonia, and rickettsial disease, Rocky Mountain spotted fever, Rickettsia rickettsii. Limited use due to toxicity, but often still used in developing countries because of low cost. The adverse effects: anemia, dose-dependent, aplastic anemia, dose-independent, gray baby syndrome in premature infants because they lack the liver UDP, glucuronidyltransferase. Mechanism: resistance, plasmid-encoded acetyltransferase inactivates the drug. What about clindamycin? The mechanism: blocks peptide translocation at the 50S ribosomal subunit, bacteriostatic. The clinical use: anaerobic infections, Bacteroides species, C. perfringens, aspiration pneumonia, lung abscesses, and oral infections, also effective against invasive group A streptococcal infection. Treats anaerobic infection above the diaphragm versus metronidazole, anaerobic infection below the diaphragm. Adverse effects: pseudomembranous colitis, C. difficile overgrowth, fever, diarrhea. What about linezolid? Well, they have this thing called oxazolidinones, which are, in this case, we're going to say oxazolidinones, which in this case we're going to say is linezolid. The mechanism: inhibits the protein synthesis by binding to the 23S rRNA of the 50S ribosomal subunit and preventing the formation of the initiation complex. Again, inhibits protein synthesis by binding to the 23S rRNA of the 50S ribosomal subunit and preventing the formation of the initiation complex. Clinical use: gram-positive species including MRSA and vancomycin-resistant enterococcus. The adverse effects of linezolid: myelosuppression, especially thrombocytopenia, peripheral neuropathy, serotonin syndrome due to the partial MAO inhibition. Mechanism: resistance, point mutation of the ribosomal RNA. What about macrolides? Macrolides: azithromycin, clarithromycin, erythromycin. The mechanism: inhibits the protein synthesis by blocking the translocation. Macroslides: binds to the 50S ribosomal subunit, bacteriostatic. Clinical use would be atypical pneumonias like mycoplasma pneumonia, chlamydia, and legionella, STIs like chlamydia, gram-positive cocci, streptococcal infections in patients allergic to penicillin, and B. pertussis. And I want to make sure I'm not saying anything correctly with that. B. pertussis. Bordetella. Oh, yeah, okay, yeah, sorry. That's a silly. I always see it as Bordetella, but they say B. pertussis. I'm like, what do you mean B? Yeah, Bordetella pertussis. Anyway, adverse effects of macrolides. Macro, gastrointestinal motility issues, arrhythmia caused by prolonged QT interval, acute cholestatic hepatitis, rash, eosinophilia, increased serum concentration of theophylline, oral anticoagulants, clarithromycin, and erythromycin inhibit cytochrome P450. And the mechanism of resistance: methylation of 23S rRNA binding site prevents binding of the drug. Okay, now we're going to go to polymyxins, which I don't know if I don't know if you have that in your book or not. I don't think you do. So you go directly into sulfonamides, I believe. So I'll talk about polymyxins for a little bit. Polymyxins: colistin, polymyxin E, polymyxin B. Mechanism: cation polypeptides that bind to the phospholipids on the cell membrane of gram-negative bacteria, disrupt cell membrane integrity, leading to leakage of the cellular components, leading to cell death. Clinical use: salvage therapy for multi-drug resistant gram-negative bacteria, for example, P. Pseudomonas aeruginosa, E. coli, Klebsiella pneumonia. Polymyxin B is a component of a triple antibiotic ointment used for superficial skin infections. The adverse effects: nephrotoxicity, neurotoxicity like slurred speech, weakness, paresthesias, respiratory failure. Sulfonamides. Sulfonamides, sulfamethoxazole, SMX, sulfasoxazole, and sulfadiazine. Mechanism: inhibits dihydroapturate synthase, thus inhibiting the folate synthesis, bacteriostatic, bactericidal when combined with trimethoprim. The clinical use: gram-positive, gram-negative, nocardia, TMP, SMX, Bactrim, trimethoprim sulfamethoxazole, right, for simple UTI. Adverse effects: Stevens-Johnson syndrome, urticaria, liver damage, folate deficiency, optic neuritis, nephrotoxicity, agranulocytosis, hemolysis of G6PD deficient, kernicterus in infants. The mechanism of resistance for sulfonamides: altered enzyme, bacterial dihydroapturate synthase, decreased uptake, or increased PABA synthesis. Okay. And you can see the little diagram right there to see where sulfonamides act on, and dapsone act on. So that's like sulfamethoxazole, that's like sulfadiazine, that kind of thing. And you can see where the trimethoprim and where the paramethamine act on right there. And so you combine those two, you combine the sulfamethoxazole and trimethoprim to make this one drug called Bactrim. And you have this other thing that's called pyrimethamine sulfadiazine, which is basically like Bactrim and acts as two drugs combined that act on the same two locations. And that would be typically for toxo. For that one. Anyway, for dapsone, similar to sulfonamides but structurally distinct agent. Clinical use: leprosy, lepromatous and tuberculoid forms, pneumocystis jirovecii, PJP, prophylaxis, or treatment when used in combination with TMP, that's trimethoprim. Adverse effects of dapsone: hemolysis of G6PD deficient, methemoglobinemia, and agranulocytosis. Some of the same stuff. What about trimethoprim? Trimethoprim mechanism: inhibits the bacterial dihydrofolate reductase, bacteriostatic. Clinical use: used in combination with sulfonamides, trimethoprim sulfamethoxazole, TMP, SMX, which is Bactrim, causing sequential block of folate synthesis. Combination used in UTIs: Shigella, Salmonella, pneumocystis jirovecii, PJP, pneumonia, pneumocystis jirovecii pneumonia, treatment and prophylaxis, toxoplasmosis prophylaxis. Adverse effects for trimethoprim: megaloblastic anemia, which should make sense to you if you understand what B12 does in the first place. What does B12 do? Think about it for a moment. Think about the mechanism of B12 and think about how this would cause megaloblastic anemia. Well, not B12, folate. Think about what folate does. Slip of the tongue. Misspeaking right there. Think about what folate does and how it operates in the body and how it operates with bacteria, and think about what is this thing doing? Why do you think something that's messing with dihydrofolate reductase might cause you to have a megaloblastic anemia? Again, it's messing with DHF reductase, dihydrofolic reductase, preventing DHF be converting to THF, which you need to have for things like DNA and RNA synthesis. Why do you think they might cause megaloblastic anemia? I don't know. It's a big mystery, right? Anyway, so back to what I was saying. Trimethoprim, hyperkalemia, and high doses, similar mechanism of potassium-sparing diuretics, megaloblastic anemia, leukopenia, granulocytopenia, which may be avoided with co-administration of leucovorin, folinic acid. Why? Because folinic acid, again, is like introducing something into that system that's going to compensate for the otherwise deficiency in that thing. TMP treats marrow poorly, yeah. Because, again, it's basically acting as a sort of anti-DNA production, anti-RNA, anti-DNA production. And so obviously you want to use that if you have bacteria that are trying to reproduce, right? But if you yourself have to make cells to produce things, and so it can cause problems for you. Leucovorin, which is another name for that, would be, I think, isn't leucovorin just folate? Leucovorin is what? Isn't it just? It says leucovorin is folinic acid, so it is folate. It's vitamin B9. So basically, if you're running into an issue saying, oh, I'm having some issues because of the trimethoprim, my Bactrim, whatever, you can use leucovorin as a way to supplement your B9 because you might be causing problems for yourself. Again, here's a pathway with PABA and tyridine via DHP synthase. Dihydroxyurate synthase becomes dihydroxyuric acid. That converts into dihydrofolic acid, and then via DHF reductase turns that DHF into THF, then THF helps you make proteins, DNA, and RNA. So, if you mess with that, that's obviously extremely important, right? So just be aware of that. Where are we now? We're in 191 right now. We wrap up on 199. Fluoroquinolones, ciprofloxacin, ciprofloxacin, ofloxacin, respiratory fluoroquinolones, levofloxacin, and moxifloxacin. Mechanism for these. Inhibits the prokaryotic enzymes topoisomerase 2, DNA gyrase, and topoisomerase 4. Bactericidal, concurrent ingestion of divalent cations, dairy, and antacids markedly decreases the oral absorption. The clinical use, gram-negative rods of urinary and GI tracts, including the Pseudomonas, some gram-positive organisms, otitis externa, community-acquired pneumonia. The adverse effects, GI upset, superinfections, skin rashes, headaches, dizziness, less commonly can cause leg cramps and myalgias, contraindicated during pregnancy or breastfeeding, and in children less than 18 years of age due to possible damage to cartilage. Some may prolong QT interval. It says here, may cause tendonitis or tendon rupture in people greater than 60 years of age and in patients taking prednisone. Ciprofloxacin inhibits the cytochrome P450. Fluoroquinolones hurt attachments to your bones, i.e. the tendons. What's the mechanism of resistance for fluoroquinolones? Again, these are things like ciprofloxacin, ofloxacin, and moxifloxacin, levofloxacin, these kinds of things. What's the mechanism against them? What's the mechanism of resistance? It's chromosome-encoded mutation in DNA gyrase, plasma-mediated resistance, and efflux pumps. Okay. What about daptomycin? Let's talk about daptomycin. Mechanism, lipopeptide that disrupts the cell membranes of gram-positive cocci by creating a transmembrane channel. The clinical use, Staph aureus skin infections, especially MRSA, bacteremia, infective endocarditis, and then VRE, which again is vancomycin-resistant enterococcus. Not used for pneumonia, avidly binds to and is inactivated by surfactant. Oh, interesting. Daptomycin is used for the skin infections but can cause myopathy. What's the adverse effects of daptomycin? Myopathy, rhabdomyolysis, which is not fun. Metronidazole. Mechanism. Forms toxic free radical metabolites in the bacterial cell that damage the DNA. Bactericidal, antiprotozoal. Clinical use. Treats Giardia, Entamoeba, Trichomonas, Gardnerella vaginalis, anaerobes like Bacteroides and C. difficile. Can be used in place of amoxicillin and H. pylori triple therapy in case of penicillin allergy. Get gap on the metro with metronidazole. Okay. Treats anaerobic infections below the diaphragm versus clindamycin, anaerobic infections above the diaphragm. So clindamycin above the diaphragm and metronidazole below the diaphragm. The adverse effects of metronidazole, disulfiram-like reaction, severe flushing, tachycardia, hypotension with alcohol, headache, metallic taste. Okay. Okay, let's see. Let me take a brief break. Anti-tuberculous drugs. Your thing says antimicrobacterial drugs. So I'll have to see with my book where my book goes into tuberculosis in this case. So let's talk about tuberculosis for a moment. Anti-tuberculous. So maybe this is a new thing that this book has, this book doesn't have. Perhaps. I'm beginning to think that now, yeah. Anti-tuberculous. Let me talk about it then. So let's talk about Oh, it's kind of in here. Let's talk about this. Let's go down a little bit. Anti-tuberculous drugs. We have the drug, the mechanism, the adverse effects, and the notes. So let's talk about rifamycin. It's rifamycin, rifampin, rifabutin, and rifapentine. Mechanism inhibits the DNA-dependent RNA polymerase, leading to decreased mRNA synthesis. Rifamycin resistance arises due to the mutations in gene encoding for RNA polymerase. The adverse effects: minor hepatotoxicity, drug interactions, CYP450 induction, red-orange discoloration of body fluids, non-hazardous adverse effect. Notes: rifabutin favored over rifampin in patients with HIV infection due to the less CYP450 induction. Monotherapy rapidly leads to resistance. Interesting. Isoniazid, INH, inhibits the mycolic acid synthesis, leading to a decrease in cell wall synthesis. Bacterial catalase peroxidase, encoded by CAT-G, is needed to convert the INH to active form. INH resistance arises due to the mutations in CAT-G. Right here. Let's talk about, okay, so that's what I'm reading from in my book. My thing looks a little bit differently. So let's go back to INH. Isoniazid, vitamin B6 deficiency. These are adverse effects. Vitamin B6 deficiency, peripheral neuropathy, sideroblastic anemia, hepatotoxicity, drug interaction, CYP450 inhibition, drug-induced lupus. INH overdose can lead to seizures, often refractory to benzodiazepines. Its notes: administer with peroxidine vitamin B6 because of the deficiency it causes from that. INH injures neurons and hepatocytes. INH, okay. Increased risk of hepatotoxicity with increased age and alcohol overuse. Different INH half-lives in fast versus slow acetylators. What about pyrazinamide? Pyrazinamide, mechanism is uncertain. Well, that's fun. Hepatotoxicity, hyperuricemia, works best at acidic pH, example in host phagolysosomes. Ethambutol inhibits the arabinosyl transferase, leading to a decrease in arabinogalactan synthesis, leading to a decrease in cell wall synthesis. Adverse effects include optic neuropathy, red-green color blindness, or decrease in visual acuity, typically reversible. The notes would be pronounced ethambutol. Pronounced ethambutol? Okay. Who decided that? Oh, because it is ethambutol, but they're saying it causes optic neuropathy as an adverse effect. Anyway, so I want to say this to you right now. These are anti-tuberculous drugs. Rifampin, isoniazid, pyrazinamide, ethambutol. They spell RIPE. That's the 4-drug regimen you would use if you have tuberculosis. So bear that in mind. When you have TB, you take these drugs: rifampin, isoniazid, pyrazinamide, ethambutol. You should probably know the mechanism as well, but this is what that is about right here. This is the picture. If you want to take a picture of that, you can. It's not as crazy, it's not as important, but it helps you understand kind of what's going on. I would definitely read about what they're talking about in this book. What about antimicrobial therapy? Antimycobacterial therapy, bacterium, prophylaxis, and treatment. So Mycobacterium tuberculosis. Prophylaxis, rifamycin-based regimen for 3 to 4 months. Treatment with rifampin, isoniazid, pyrazinamide, ethambutol. RIPE for treatment. Wow. Mycobacterium avium Mycobacterium avium intracellularare. Azithromycin, rifabutin. Treatment: azithromycin or clarithromycin plus ethambutol. Can add rifabutin or ciprofloxacin as well. Mycobacterium leprae. Prophylaxis: none. What do you do for treatment? Long-term treatment with dapsone and rifampin for tuberculoid form, but you add clofazimine for lepromatous form. So you basically do dapsone and rifampin as a baseline. If it's lepromatous form, which is the worst kind, the worst of the two, the last bad is tuberculoid form, right? The worst of the two is lepromatous form. You want to add clofazimine on top of that, clofazimine. So there's that chart again I was talking about. There's just describing the RIPE drugs, basically. What about antimicrobial prophylaxis? About a clinical scenario and then medication. So I'm going to play a little bit of a guessing game again. You can do it here. Exposure to clinical scenario, Medication. Exposure to meningococcal infection. What do you do? Ceftriaxone, ciprofloxacin, or rifampin. High risk for infective endocarditis and undergoing surgical or dental procedures. What do you do? Give them amoxicillin. History of recurrent UTIs. What do you give them? Bactrim. What about malaria prophylaxis for travelers? What can you do? Atopiquone, proguanil, mefloquine, doxycycline, primaquine, or chloroquine for areas with sensitive species. Okay, I don't exactly know what that. I'm not quite sure what they mean. Chloroquine for areas with sensitive species, like this. I don't know. I'm not exactly sure entirely what they mean. Maybe like some sort of pollution issue. I'm not quite sure. Pregnant patients carrying Group B strep, intrapartum penicillin G or ampicillin. Prevention of gonococcal conjunctivitis in newborns. Erythromycin ointment on eyes. Prevention of post-surgical infection due to Staph aureus. Cefazolin, vancomycin if positive for MRSA. Prophylaxis of strep pharyngitis in child with prior rheumatic fever. What do you give them? Benzathine penicillin G or oral penicillin V. What about prophylaxis in HIV patients? What do we do about this? Let's say the patient has a CD4 count less than 200. So basically they have AIDS. They just got AIDS, okay? They're below CD count of 200. What do we give them? Bactrim. The infection, what can they get? Pneumocystis pneumonia. What if they have a CD4 count less than 100? What do we give them? Bactrim again. Infection, pneumocystis pneumonia, and toxoplasmosis. And then CD4 count less than 50. My book doesn't have this, but I think it's relevant, and it's in your older book, so I'll read about it. What do you give them if it's less than 50? That's really bad. What do you give them? Azithromycin or clarithromycin. Those are macrolides. Why do you give them a macrolide like that? For MAC. Mycobacterium avium complex. Remember, if it's below 50, and they have some sort of presentation that would suggest either MAC or toxo. If it's below 50, it's MAC. If it's above 50, it's probably TB, I think, right? I want to make sure that I'm not saying anything incorrectly. I'm saying yes. In patients with advanced HIV/AIDS, Mycobacterium avium complex (MAC) often presents as a disseminated multi-organ infection because both are mycobacterium. Symptoms can look nearly identical to TB, which frequently causes diagnostic challenges. Yeah. So basically, it's this: if a patient has AIDS, okay, they got AIDS. If it's below 50 and they have like TB-like symptoms, it's probably MAC. But if it's above 50, if the CD4 count is above 50, it's probably TB. So above 50 TB, below 50 MAC, okay? But they look kind of similar to each other otherwise for these kinds of AIDS patients. Anyway. We have antifungal therapy. There's a little diagram for that as well. Going over linosterol synthesis with terbinafine, ergosterol synthesis with azoles, nucleic acid synthesis with flucytosine, so membrane integrity with polyenes, and cell wall synthesis with echinocandins. So we'll be going over those now, but that's a good chart to kind of like sum it up on what's going on for each. So if you want to take a picture of that, you can. Put it to your notes or whatever you do with them. And I'm just trying to think about the setup for things. We're on page 194 for reference, and we're going to wrap up on 199. Where are we now in terms of the cut? Okay, we're on 148 right now. So we'll probably get done 220-ish maybe, I would guess. Antifungal therapy. Let's talk about amphotericin B, the mechanism. We have mechanism, then clinical use, and then adverse effects. So mechanism of amphotericin B. It binds ergosterol, unique to fungi. Yeah, ergosterol is unique to the fungi, which is why it's very specific, I guess you could say. Binds ergosterol, forms membrane pores that allow leakage of electrolytes. Here's a little note here for you. Amphotericin tears holes in the fungal membrane to form pores. Not too bad. Clinical use, serious systemic mycoses, Cryptococcus, amphotericin B, plus or minus flucytosine for cryptococcal meningitis, blastomyces, coccidioides, histoplasma, candida, and mucor, intrathecally for coccidioidal meningitis. Note here it says supplement potassium and magnesium because of altered renal tubule permeability. Okay. What are the adverse effects of amphotericin B? Fever/chills, shake and bake, hypotension, nephrotoxicity, arrhythmias, anemia, IV phlebitis, amphoterable. Okay, well that's not very specific in my opinion. What do you do? Hydration decreases nephrotoxicity. Liposomal amphotericin B decreases the toxicity as well. What about nystatin? Nystatin mechanism, same as amphotericin B. Okay. Topical use only as too toxic for systemic use. So it's topical. You got to keep it topical because it's too strong. Clinical use, swish and swallow for oral candidiasis, thrush. Topical for diaper rash or vaginal candidiasis. What about flucytosine? Flucytosine mechanism inhibits the DNA and RNA biosynthesis by conversion to the 5-fluorouracil by cytosine deaminase. The clinical use, systemic fungal infections, especially for meningitis caused by Cryptococcus in combination with amphotericin B. It can cause, though, myelosuppression. What about azoles? Azoles, clotrimazole, fluconazole, isofluconazole, itraconazole, ketoconazole, mycoconazole, and voriconazole. A lot of different kind of conazole. A lot of azoles there. Mechanism for azoles? They inhibit the fungal sterol, ergosterol synthesis. They mess with the synthesis of ergosterol by inhibiting the cytochrome P450 enzyme that converts lanasterol into ergosterol. Clinical use, local and less serious systemic mycoses, fluconazole for chronic suppression of the cryptococcal meningitis in people living with HIV, and candidal infections of all types. Itraconazole may be used for blastomyces, coccidioides, histoplasma, sporothrix shanki, clotrimazole and miconazole for fungal infections, voriconazole for aspergillus and some candida, isofluconazole for serious aspergillus and mucor infections. The adverse effects, testosterone synthesis inhibition, gynecomastia. Okay, that's not very fun. Especially with ketoconazole. Ketoconazole can cause that. Remember, ketoconazole also is used to prevent hair loss, by the way, in men, because men will have DHT, which causes hair loss, related to hair loss, and so they want to prevent, some people try to prevent that happening by using ketoconazole, which will kind of inhibit some of those androgenic effects. Unfortunately, it also causes gynecomastia. Okay, so, double-edged sword with that one. Liver function, inhibits cytochrome P450, QT interval prolongation. What about terbinafine? Terbinafine inhibits the fungal enzyme squalene epoxidase. Clinical use, dermatophytoses, especially onychomycoses, fungal infection of the finger or toenails. The adverse effects, GI upset, headaches, hepatotoxicity, taste disturbance. What about echinocandins? Echinocandins, anti-dulafungin, caspofungin, micafungin. The mechanism, inhibits the cell wall synthesis by inhibiting the synthesis of beta-glucan. Clinical use would be invasive aspergillosis in Candida. The adverse effects of echinocandins, GI upset, flushing by histamine release. What about griseofulvin? Griseofulvin. It interferes with the microtubule function, disrupts mitosis, deposits in keratin-containing tissues like nails. The clinical use of griseofulvin, oral treatment of superficial infections, inhibits the growth of dermatophytes like tinea and ringworm. The adverse effects would be teratogenic, carcinogenic, confusion, headaches, disulfiram-like reactions, increased cytochrome P450, and warfarin metabolism. Okay. What about antiprotozoal therapy? Antiprotozoal therapy, pyrimethamine sulfadiazine, toxoplasmosis, suramin and melarsoprol for Trypanosoma cruzi, nifurtimox for T. cruzi, Trypanosoma cruzi, sodium sibugluconate for leishmaniasis. Okay. Very, rapid fire, kind of. That really doesn't explain exactly what each of those do in terms of mechanism, but whatever. Anti-mite/louse therapy. Permethrin, malathion, acetylcholinesterase inhibitor. Topical or oral ivermectin. Used to treat scabies, Sarcoptes scabii, and lice, pediculus and pteris. Okay. What about chloroquine? Chloroquine. Mechanism. Blocks detoxification of heme into hemozoin. Heme accumulates in its toxic plasmodia. Clinical use, treatment of Plasmodial species other than P. falciparum due to the drug resistance from membrane pump that decreases the intracellular concentration of the drug. Adverse effects, retinopathy, dependent on cumulative dose, pruritus, especially in dark-skinned individuals. Okay. We're getting there. 196. Antihelminthic therapy. Parental pamoate, ivermectin, mebendazole treats bendy worms. Okay. Also, albendazole, mebendazole, both of those are bendazoles, or whatever. Mebendazole treats bendy worms by disrupting microtubules and cellular motility. Praziquantel, which increases the calcium permeability, and vacuolization increases with it, and diethylcarbamazine. What about oseltamivir and zanamivir? Let's talk about that. Oh, here's another chart for you. Look at that. I don't know if I even have that much chart in my thing. I don't think I have a different chart, but not that one. So if you want to use that, you can. Up to you. I think it might be useful. Oseltamivir and zanamivir. So you can take a picture of that, and I'll go to my section. Oseltamivir, zanamivir inhibits the influenza neuraminidase, leading to a decrease in release of progeny virus. Clinical use, treatment and prevention of influenza A and B, beginning therapy within 48 hours of symptoms onset may shorten duration of illness. Baloxavir. Baloxavir inhibits the cap-snatching transfer of the 5' cap from the cell mRNA onto the viral mRNA. Endonuclease activity of the influenza virus RNA polymerase leads to a decrease in viral replication. The clinical use of baloxavir would be the treatment within 48 hours of symptom onset to shorten duration of the illness. Remdesivir. Where are we even with this stuff? What's going on, man? Cidofovir, foscarnet, ganciclovir, oseltamivir, zanamivir. Do we have anything else? No, we don't. So let's go into remdesivir, which I assume is about COVID, isn't it? So that's not going to be in this book because this is 2017, but just listen to what I'm saying. Remdesivir, mechanism. Prodrug of an ATP analog. The active metabolite inhibits the viral RNA-dependent RNA polymerase and evades proofreading by viral exoribonuclease exon, leading to a decrease in viral RNA production. Clinical use for remdesivir would be recently approved for treatment of COVID-19 requiring hospitalization. What about acyclovir, famciclovir, and valacyclovir? Mechanism, guanosine analogs, monophosphorylated by HSV/VZV, thymidine kinase, and not phosphorylated in uninfected cells, leading to few adverse effects. Triphosphate formed by cellular enzymes preferentially inhibit the viral DNA polymerase by chain termination. Clinical use, no activity against CMV because CMV lacks the thymidine kinase necessary to activate guanosine analogs. Used by HSV-induced mucocutaneous and genital lesions as well as for encephalitis. Prophylaxis in patients who are immunocompromised. Also used as prophylaxis for immunocompetent patients with severe or recurrent infection. No effect on latent forms of HSV and VZV. Valacyclovir, a prodrug of acyclovir, has a better oral bioavailability. Just bear that in mind. When they say valacyclovir is a prodrug of acyclovir and has better bioavailability, valganciclovir is a prodrug of ganciclovir and has better bioavailability than the original ganciclovir. Make sense? The val part of those names will indicate to you that they are a prodrug. I don't know if that's consistent across the board for all drugs that have that, but for valacyclovir and valganciclovir, they are prodrugs of acyclovir and ganciclovir respectively, and they do have better bioavailability compared to their, compared to the drug that they are a prodrug for. Anyway, where were we? For herpes zoster, use famciclovir. Adverse effects of acyclovir, etc. Obstructive crystalline nephropathy and acute kidney injury if not adequately hydrated. Mechanism of resistance, mutated viral thymidine kinase, which will prevent it from being activated. Ganciclovir. Remember, there's another thing called valganciclovir, which is a prodrug, which I think they mentioned in this thing anyways. So ganciclovir mechanism, guanosine analog, 5' monophosphate formed by the CMV viral kinase, Triphosphate formed by cellular kinases preferentially inhibits the viral DNA polymerase. The clinical use, CMV, especially in patients who are immunocompromised. Valganciclovir is a prodrug of ganciclovir, which has better bioavailability. Adverse effects, myelosuppression, leukopenia, neutropenia, thrombocytopenia, renal toxicity, more toxic to host enzymes than acyclovir. Mechanism resistance, mutated viral kinase. Now we're going to go to Foscarnet. Mechanism, viral DNA RNA polymerase inhibitor and HIV reverse transcriptase inhibitor, binds to the pyrophosphate binding site of the enzyme, does not require any kinase activation. Foscarnet equals pyrophosphate analog. Clinical use, CMV retinitis in immunocompromised patients when ganciclovir fails, acyclovir-resistant HSV as well. And the reason is because it basically bypasses the need for the thymidine kinase, or for that matter, the CMV viral kinase. So they don't need the kinase for activation. It kind of sidesteps that entirely. And so if you have some sort of resistant thing to those drugs, ganciclovir or acyclovir, you can use this instead. Clinical use, CMV retinitis for Foscarnet, clinical use, CMV retinitis in immunocompromised patients when ganciclovir fails, acyclovir-resistant HSV. Adverse effects of Foscarnet, nephrotoxicity, multiple electrolyte abnormalities can lead to seizures. Mechanism resistance, mutated DNA polymerase. What about cidofovir? Cidofovir mechanism preferentially inhibits viral DNA polymerase. It does not require phosphorylation by viral kinase. Hence, again, is another alternative if you have an issue with the resistance from viral kinase that gets mutated, and so we can't use acyclovir for it for some reason. And the viral kinase can't be used because it's mutated. You can use cidofovir or Foscarnet as an alternative. So back to cidofovir. Clinical use, CMV retinitis in immunocompromised patients, long half-life. Adverse effects of it, nephrotoxicity, co-administer with cidofovir with probenecid and IV saline to decrease toxicity. True. Probenecid. A mechanism of resistance, mutations in the viral DNA polymerase gene. So if you have a DNA polymerase gene mutation, sure, that's still going to cause a problem for it, but thymidine kinase problems would not be an issue because it doesn't need that for activation. What about HIV therapy? I'm not sure if your book has that or not. Yes, it does. HIV therapy. Antiretroviral therapy, ART, often initiated at the time of HIV diagnosis. Strongest indication for use with patients presenting with AIDS-defining illnesses, low CD4 positive cell counts, less than 500, or high viral load. Regimen consists of 3 drugs to prevent resistance, 2 NRTIs, and preferably an integrase inhibitor as well. Most ARTs are active against both HIV-1 and HIV-2. Exceptions include NNRTIs and infuvritide, which are not effective against HIV-2. Tenofovir plus emtricitabine can be administered as a pre-exposure prophylaxis. So what about the drug mechanism and toxicity? Abacavir, emtricitabine, lamivudine, tenofovir, cidovudine, which is formerly... Okay. So what about them? Mechanism. Competitively inhibits the nucleotide binding to the reverse transcriptase and terminates the DNA chain lacking the 3' OH group. Tenofovir is a nucleotide. The others are nucleosides. All need to be phosphorylated to be active. The cidovudine can be used for general prophylaxis and during pregnancy to decrease the risk of fetal transmission. Have you dined verdine with my nucleoside family? Okay. That's not, I would not use that one. But anyway, adverse effects of these things, toxicity, myelosuppression can be reversed with granulocyte colony stimulating factor, GCSF, and erythropoietin. Nephrotoxicity as well. Abacavir contraindicated if patients has a HLA-B5701 mutation due to the increased risk of hypersensitivity. What about NNRTIs? NNRTIs, which are the non-nucleoside reverse transcriptase inhibitors, what about those? Well, we have doravirine, evavirenz, and ribavirin. They bind to the reverse transcriptase at site different from the NRTIs. They do not require phosphorylation to be active or compete with the nucleotides. They can cause, though, a rash and hepatotoxicity and are common to all NNRTIs. Vivid dreams and CNS symptoms are common with efavirenz. That's weird. What about integrase strand transfer inhibitors? We have bictegravir and dolutegravir. And your book also has this third thing called elvitegravir, but See the TGRA for that, for integrase inhibitor? Also called an integrase inhibitor, inhibit the HIV genome integration into the host cell chromosome by reversibly inhibiting the HIV integrase. The toxicity, though, the adverse effects would be increased creatinine kinase, and it can cause weight gain. Interesting. Okay, now I'm going to go to HIV therapy continued, talking about protease inhibitors. So protease inhibitors, atazanavir, darunavir, leponavir, ritonavir. The navir is important for this one, for the naming. For protease inhibitors, navir prevents maturation of new virions. Maturation depends on HIV-1 protease, POLT gene, which cleaves the polypeptide products of HIV mRNA into the functional parts. All protease inhibitors require boosting with either ritonavir or cabacistat. Navir never tease a protease. Adverse effects: hyperglycemia, GI intolerance, nausea, diarrhea. Rifampin, potent CYP UGT inducer, decreased protease inhibitor of concentrations. Use rifabutin instead. Ritonavir, cytochrome P450 inhibitor, is only used as a boosting agent. Let's talk about entry inhibitors now. Entry inhibitors. Do we have anything on that? Like influvatride and maraviroc? Do we have anything like that? Right here, fusion. They call them fusion inhibitors, which is what I've heard them as before, but they call them entry inhibitors in my book. So they call them entry inhibitors or fusion inhibitors. So the name gives it away for this influvatride for fusion inhibitor. So binds to the GP41, inhibiting the viral entry. Influvatride inhibits fusion. Adverse effects of this, though: skin reaction at injection sites. What about maraviroc? Maraviroc binds to the CCR5 on the surface of T cells/monocytes, inhibiting the interaction with GP120. Maraviroc inhibits docking. My book has a little diagram for this stuff about maraviroc and influvatride. I don't think you have that. Maybe you do. Do you have that? Yeah, you do. So my book has it on one side. All the stuff on the left side, it says antiviral therapy. All that's on the left side is what I have in my book. And you have this second graph, which is about other antiviral therapy, which I do not have. Or at least I don't think I do not have that. Okay. So you're doubling up somehow. I only have halfway house, apparently. I only got half the stuff from this new book. So let's go back into it. But, just be aware of this, how that works. Antiviral therapy. Okay, what about hepatitis C therapy? Do we have that? Hep C therapy. Chronic HCV infection treated with multi-drug therapy that targets the specific steps within HCV replication cycle, HCV-encoded non-structural proteins. Examples of drugs are provided. The drug, mechanism, and toxicity. So the NS5A inhibitors, elbasavir, ledipasvir, pibrentasvir, and velpetasvir. These asvirs are the NS5A inhibitors. What do? They inhibit the NS5A, of course, a viral phosphoprotein that plays a key role in RNA replication. Exact mechanism is unknown. The toxicity is headache and diarrhea. What about the NS5B inhibitors? Sulfospivir, right? Well, these inhibit the NS5B, an RNA-dependent RNA polymerase acting as a chain terminator, prevents viral RNA replication. It can cause fatigue and headache, though. What about NS3-4A inhibitors? Well, these are going to include glecaprevir and grazoprevir. And I also think simipravir. I've always heard of simipravir, S-I-M-E, previr. But they only have glecaprevir and grazoprevir in my book. Do you have simipravir in your book? Wow, that's crazy. So, but that is an NS3 or NS3-4A inhibitor, though. Maybe that's not the most up to date, but that is one of them, and I'm surprised I didn't even include that in here. But those glecaprevir, grazoprevir, and simipravir, they inhibit the NS3-4A, a viral protease preventing the viral replication. They can cause headaches and fatigue. Okay, so the adverse effects are pretty similar to each other. What about alternative drugs for Hep C therapy? Ribavirin, it inhibits the synthesis of guanine nucleotides by competitively inhibiting the IMP dehydrogenase. This can cause, though, hemolytic anemia and it's a severe teratogen. So it's a little bit different in terms of adverse effects. Let's go into disinfection and sterilization. little short category. Mine's a little bit longer. It says here, disinfection, sterilization. Goals include the reduction of pathogenic organisms counts to safe levels, disinfection, and the inactivation of all microbes, including spores, which is sterilization. So disinfection is when it's safe, theoretically safe, right? Reduction is safe enough. But sterilization is when it's done for, it's gone. Including the spores, which is a lot harder to do, admittedly. What about an autoclave? Pressurized steam at greater than 120 degrees Celsius may not be reliably inactivate prions. Remember, prions are not even alive, they are literally proteins that are misfolded. Alcohols, they denature proteins and disrupt cell membranes. Chlorhexidine disrupts cell membranes and coagulates intracellular components. Chlorine oxidizes and denatures proteins. Ethylene oxide, alkylating agent. Hydrogen peroxide, free radical oxidation. Iodine and iodophores, the halogenation of DNA, RNA, and proteins may be sporicidal. Okay. Quaternary amines impairs the permeability of cell membranes. And just for reference, autoclaves, chlorine, ethylene oxide, hydrogen peroxide, those are all sporicidal. The iodine and iodophores might be sporicidal. Quaternary amines are not sporicidal. Alcohols are not sporicidal. And nor is chlorhexidine sporicidal. Those ones are not. What about antimicrobials to avoid in pregnancy? So these are things that might be, I guess, teratogenic. Antimicrobial and the adverse effects. So sulfonamides, they say, can cause kernicterus in the child. Aminoglycosides, ototoxicity. Fluoroquinolones, cartilage damage. Clarithromycin, embryotoxic. Tetracyclines, discolored teeth, inhibition of bone growth. Ribavirin is teratogenic. Griseofulvin is teratogenic. Chloramphenicol causes gray baby syndrome. And here's a little mnemonic here for your little learning device. Safe children take really good care. Okay. If that helps you learn, that's fine. Anyway, so that was the last page. That was 199. And that concludes our chapter for today. We are now done with the last section, section 7 for the microbiology chapter. Again, this is the microbiology chapter from the first aid for the USMLE Step 1 textbook, 2025 edition, 2017 edition on my PDF that I'm showing you here. This was one of the longer chapters that exists in the book, but it is a very important chapter. Again, for the exams, there's a big focus on the bugs and the drugs. And if you don't know those categories, if you don't know the actual microbes that can cause disease, and you don't know the drugs you can use to treat diseases and how the mechanisms work and everything like that, you're not going to do very well in the exams. So just bear that in mind. This is a very important chapter to know. And of course, I'd recommend, if you want to look more into things like sketchy micro, for example, if you want to look at Boards and Beyond videos or whatever helps you learn this topic, you can go right ahead. Of course, some of those are paid services in theory. But, see what works for you. But this is a very good textbook to read from for this topic, for the board exam, for Step 1 and for COMLEX. If you've been here in the video for this long, well, hopefully it was a good use to you. Thank you very much for watching, and bye.